Welcome to the MRCS Bite session on autonomic nervous system and spine anatomy and pathology, OSCE Station 1. Today, we'll dive into this topic and explore the common questions tested during the MRCS Part B exam. For more information and full course, please visit mrcsbites.com. Question 1. What is the origin of the sympathetic nervous system? The sympathetic nervous system originates from the thoracolumbar region of the spinal cord, specifically from the intermediolateral cell column of the spinal cord segments T1 to L2. These preganglionic sympathetic neurons send their axons out through the ventral roots to the sympathetic ganglia, where they synapse with postganglionic neurons. The sympathetic nervous system is part of the autonomic nervous system, which controls involuntary bodily functions. Question 2. What is the nerve supply to the heart? The heart receives its nerve supply from both the sympathetic and parasympathetic branches of the autonomic nervous system. Sympathetic nerve fibers originate from the thoracic spinal cord segments, T1 to T5. They travel to the heart through the sympathetic trunk and form the cardiac plexus. These fibers release norepinephrine, which increases heart rate and force of contraction. Parasympathetic nerve fibers come from the vagus nerve, cranial nerve 10. They also contribute to the cardiac plexus and release acetylcholine, which decreases heart rate and reduces the force of contraction. Question 3. What is the nerve supply to the foregut? The nerve supply to the foregut comes from both the sympathetic and parasympathetic branches of the autonomic nervous system. Sympathetic innervation to the foregut originates from the thoracic spinal cord segments, T5 to T9. Preganglionic sympathetic fibers travel through the splanchnic nerves, greater and lesser splanchnic nerves, to the celiac ganglion, where they synapse with postganglionic neurons. These postganglionic fibers then innervate the foregut organs, including the stomach, liver, pancreas, and proximal duodenum. Parasympathetic innervation is primarily provided by the vagus nerve, cranial nerve 10. The vagus nerve supplies the foregut organs with preganglionic parasympathetic fibers that synapse in or near the target organs, where they influence digestive processes, including increasing motility and secretions. Question 4. What is the nerve supply to the hindgut? The nerve supply to the hindgut involves both sympathetic and parasympathetic branches of the autonomic nervous system. Sympathetic innervation to the hindgut originates from the lumbar spinal cord segments, L1 to L2. Preganglionic sympathetic fibers travel through the lumbar splanchnic nerves to the inferior mesenteric ganglion. Here, they synapse with postganglionic neurons. The postganglionic fibers then travel to the hindgut, including the distal colon and rectum. Parasympathetic innervation to the hindgut is primarily provided by the pelvic splanchnic nerves, S2 to S4. These preganglionic parasympathetic fibers synapse in or near the target organs. They are responsible for promoting peristalsis and increasing secretions in the hindgut. Question 5. What does the hypogastric plexus and nerves innervate? The hypogastric plexus and its associated nerves primarily innervate structures in the pelvic region. Their functions include bladder. The hypogastric plexus provides sympathetic innervation to the bladder, influencing bladder contraction and relaxation, and affecting urinary storage. Reproductive organs. In males, the hypogastric plexus innervates structures such as the prostate gland and the seminal vesicles, influencing their secretory functions and erectile function. In females, it innervates the uterus, ovaries, and vaginal structures, affecting uterine contraction and vaginal blood flow. Rectum. The hypogastric plexus provides sympathetic input to the rectum, helping to regulate its motility and tone. Other pelvic organs includes the internal anal sphincter and the erectile tissues of the penis and clitoris. Question 6. In what surgeries do the hypogastric plexuses get damaged? Damage to the hypogastric plexuses can occur during surgeries involving the pelvic region. Some common procedures where this can happen include prostate surgery. Radical prostatectomy, performed for prostate cancer, can damage the hypogastric plexus due to its proximity to the prostate gland. This may affect erectile function and other autonomic functions. Gynecological surgery. Procedures such as hysterectomy, removal of the uterus, especially when performed with extensive pelvic dissection, can damage the hypogastric plexus. This may impact functions related to the bladder, rectum, and sexual organs. Rectal surgery. Surgical procedures on the rectum, such as rectal cancer resection, can potentially involve the hypogastric plexus, affecting bowel and bladder functions. Pelvic tumor resection. Surgery to remove tumors from the pelvic region, including those in the bladder, uterus, or other pelvic organs, can inadvertently affect the hypogastric plexus. Abdominopelvic surgery. Any extensive surgical procedures in the lower abdomen and pelvis, such as those for complex trauma or large hernia repairs, may risk damaging the hypogastric plexus. Damage to the hypogastric plexuses can lead to complications such as erectile dysfunction, bladder dysfunction, and bowel issues. Surgeons typically take care to minimize such risks by preserving these structures when possible. Question 7. What nerves contribute to the micturition process? The micturition process, or the process of urination, involves a complex interplay of both sympathetic and parasympathetic nervous systems, as well as somatic motor control. The key nerves involved are pelvic splanchnic nerves, S2, S4. These nerves are crucial for the micturition process. They innervate the detrusor muscle of the bladder, stimulating it to contract and thereby facilitating the expulsion of urine. The activation of these nerves leads to the contraction of the bladder and relaxation of the internal urethral sphincter, allowing urine to flow out of the bladder. Hypogastric nerves, T11L2. These nerves provide sympathetic innervation to the bladder, primarily influencing bladder storage. They cause the detrusor muscle to relax and the internal urethral sphincter to contract, which helps retain urine in the bladder. Pudendal nerve, S2, S4. This nerve innervates the external urethral sphincter, a voluntary muscle that helps control the initiation and cessation of urination. Contraction of this sphincter prevents urine from being released, while its relaxation allows urine to flow. Question 8. What is the etiology of a reflex bladder in patients? A reflex bladder, also known as a spastic bladder, is characterized by involuntary contractions of the bladder muscle, detrusor muscle, leading to frequent and sometimes uncontrollable urination. The etiology of a reflex bladder typically involves neurological conditions that disrupt normal bladder function. Here are some common causes. Spinal cord injury. Damage to the spinal cord, particularly above the sacral level, can disrupt the normal communication between the bladder and the brain. This often results in a loss of voluntary control and an increase in involuntary bladder contractions. Multiple sclerosis. MS can affect the central nervous system, leading to a range of bladder dysfunctions, including a reflex bladder. The demyelination in MS can interfere with the pathways that control bladder function. Stroke. A stroke can affect the areas of the brain responsible for controlling bladder function, leading to a spastic or reflex bladder. Traumatic brain injury. Injuries to the brain can impact the neural pathways involved in bladder control, resulting in a reflex bladder. Neurological disorders. Conditions like Parkinson's disease or spinal cord tumors that affect the central nervous system can also lead to reflex bladder issues. Question 9. Describe the blood supply to the spinal cord. The blood supply to the spinal cord is provided by several arteries that ensure its proper oxygenation and nutrient delivery. Here's a breakdown. Anterior spinal artery originates from the vertebral arteries, which branch from the subclavian arteries. Runs along the anterior, ventral aspect of the spinal cord. Supplies the anterior two-thirds of the spinal cord, including the anterior horn and the anterior columns. Posterior spinal arteries usually arise from the posterior inferior cerebellar arteries, PICA, but sometimes from the vertebral arteries directly. There are typically two posterior spinal arteries, one on each side. They run along the posterior, dorsal aspect of the spinal cord. Supply the posterior one-third of the spinal cord, including the posterior columns and the dorsal horn. Radicular arteries. These are branches of the segmental arteries that supply the nerve roots and the anterior and posterior spinal arteries. They are distributed along the length of the spinal cord and reinforce the spinal cord's blood supply. Segmental arteries arise from the aorta and supply the spinal cord through the radicular arteries. These arteries are crucial for maintaining adequate blood flow to the spinal cord. In addition to these main arteries, there are also anastomoses, connections, between the anterior and posterior spinal arteries that help ensure a continuous blood supply, even if one part of the system is compromised.